I think because of time, I'm going to get started. I think Professor Kim will be here anytime. So I'm Alan Yeung. We have an esteemed panelist group, Dr. Kim, Dr. Lam, Dr. Soo, Dr. Tada, and Dr. Watanabe, Dr. Yeung, and Dr. Yu. So we're going to start with Dr. Eberhard Grube. He's going to talk about considerations of asymptomatic severe AS or moderate AS.
Is the mouse working? Oh, okay. Thank you very much, Alan. The topic of my talk will be severe asymptomatic and moderate aortic stenosis. These are my disclosures again. So basically, asymptomatic and moderate aortic stenosis are the next step in TAVR, and obviously we are approaching it for a good reason. We want to detect early cardiac damage to avoid permanent and irreversible damage that is actually improving and impacting long-term outcomes. So if we look at the TAVR next step, the mortality in untreated aortic stenosis patients, and you can see here the 4-year treatment rate versus the 4-year mortality rate. And that is very disturbing, as you can see here. The treatment rate is fairly low and the mortality is high, looking at mild to moderate, and moderate aortic stenosis. So that is why we're actually looking at this, and not only in aortic stenosis, but also in aortic insufficiency. We have to improve patient selection and actually disease awareness, because we have to look at non-cardiac comorbidities, at concomitant cardiac disease, and the frailty. In severe aortic stenosis, waiting for symptoms as the main trigger for replacement results in more cardiac damage, which is not reversible after replacement, and predicts long-term adverse clinical outcomes. 30% of patients undergoing TAVR derive no or minimal symptom benefit and die within 1 year. That is disturbing, and we should be doing better. In this study that's shown here, patients with mild aortic stenosis, cardiac damage was a common manifestation even in the earlier stages of aortic stenosis. Cardiac damage was highly associated with comorbidities and not associated with valvular hemodynamic status. The degree of cardiac damage in patients with mild AS was associated with all-cause mortality. This implies that comorbidities, rather than mild alterations in valvular hemodynamics, are major contributors to cardiac damage in the early stage of aortic stenosis. We have to digest this, at least in this study. So looking at early intervention, what are the lessons that we learned so far? Asymptomatic severe aortic stenosis, additional learnings from surgery. As you can see, as with many surgical trials, low patient numbers. Early intervention is superior to clinical supervision. Recovery trial, 145 patients, and the AVADA trial, 157 patients. Early intervention is superior to surveillance. The news for TAVR has been recently discussed and published, the early TAVR trial and the EVOLVE trial. We know early TAVR trial is a randomization of the SAPIEN versus clinical surveillance. And the EVOLVE trial is different, both by design as much as by the purpose of the study. The screening in this trial excluded low-risk patients with normal ECGs and or normal high-sensitivity troponin. It is important to note that cardiovascular magnetic resonance included at high risk with non-infarct myocardial fibrosis on that investigation. So EVOLVE trial has a different approach. They wanted to find out whether it's possible to identify a cohort of patients with increased risk. CMR known to be a predictor of increased mortality following interventions. We all know the results. The early TAVR trial was a positive trial and the EVOLVE trial was a negative trial. If we look at this, then we have to first of all look at the differences between those two trials. If we look at the timing of early TAVR and evolved of intervention, the timing of intervention, you can see there's a big difference between early TAVR and evolve. Time to replacement in early TAVR, 14 days, and in the evolved, 152 days. There's a big difference here. From randomization, 11 months versus 614 days, and upon symptoms development, indication for replacement, 32 days versus 100 days. So there is a difference in the timing of intervention, which actually might impact outcomes. This is the symptoms in early TAVR and conversion to replacement. You can see in green a little bit of patients with no symptoms, in yellow, progressive signs and symptoms, and in red, advanced signs and symptoms. Eventually, you can see they all converted to TAVR. And it's interesting also, the symptoms in the majority of patients were dyspnea, dizziness, and fatigue. Only 10 patients, or 9%, experienced the classic sign of syncope. The clinical presentation at the time of AVR conversion are classified here, green, yellow, and red, advanced symptoms that eventually led to replacement. Also interesting in the follow-up discussions with early TAVR, the stage of cardiac damage at baseline. 85% of patients enrolled showed signs of cardiac damage. If we look at this again, cardiac damage in early TAVR and asymptomatic severe AS, the treatment effect was consistent across various stages of cardiac damage. More than 75% in the clinical surveillance arm also showed stable or improving signs of cardiac damage during follow-up. So there's no clear to be treated group that could be identified based on cardiac damage alone. Other factors can or need to be incorporated and considered. Then stratification based on biomarkers. We can see no clear signal for guiding the timing of intervention based on single biomarker measurements. If we look at the summary of evidence in asymptomatic severe aortic stenosis, we can see here in the meta-analysis of early TAVR, evolved, recovery, and avatar, we can clearly see that looking at mortality, cardiovascular mortality, heart failure, hospitalization, unplanned CV or heart failure, hospitalization, and stroke, clearly in favor of early intervention. So in summary, asymptomatic severe AS resulted in a significant reduction of the primary endpoint, death, stroke, or unplanned CV hospitalization, was not associated with excess mortality or stroke, prevented a clinically meaningful decline in quality of life in clinical surveillance patients who subsequently converted to replacement, and improved measures of LV and LA function. The strategy of preemptive TAVR for severe asymptomatic aortic stenosis is safe, with no access hazard related to early intervention. Reducing early hospitalization for progressive symptoms or urgent treatment may reduce stroke through mechanisms that merit further exploration. So if we look at the clinical implication of the results so far, watchful waiting is no longer appropriate. Earlier diagnosis and preparation for intervention is needed. Educational initiatives across referral networks have to be established, and of course the guidelines have to be updated. Moving on to moderate aortic stenosis, and we know watchful waiting so far is ingrained in our clinical practice so far. But moderate aortic stenosis is not a benign disease. The TAVR Unload trial, for many reasons, some unfortunate reasons, are a randomization between transfemoral TAVR and clinical aortic stenosis surveillance. We also know the results. Negative trial. The major events, both MACE and all-cause death, with no difference in surveillance and the treatment group. However, if we look at the competing risk analysis, you can see in the upper line, dead or no TAVR was declining, and patients receiving TAVR were increasing. So at 3.5 years, patients were either dead or had received TAVR. 43% of clinical surveillance group underwent TAVR, mostly because of progression to severe aortic stenosis. Moderate aortic stenosis with heart failure in the TAVR Unload trial. In the conclusion, Moderate AS is well tolerated by a good ventricle, but poorly tolerated by a failing ventricle. Moderate AS with heart failure is associated with poor prognosis. There's no indication so far for replacement in patients with moderate AS and heart failure unless they have an indication for cardiac surgery. Closer clinical and echo follow-up every year is recommended for at-risk moderate aortic stenosis. Clinical takeaways: asymptomatic severe AS, rather sooner than later TAVR will be indicated and needed. Implications for clinical practice: as soon as severe asymptomatic AS is diagnosed, full workup including CT and game plan is mandatory. In moderate aortic stenosis, frequent follow-up is mandatory. More evidence of the role of replacement is needed, and more evidence is coming. In asymptomatic AS, the Donovan trial, EASY trial, and in moderate aortic stenosis, the PROGRESS trial with balloon expandable valve and EXPAND TAVR 2 trial with self-expanding valves. So the established treatment term, as we know from Braunwald, is on the right side, looking at symptoms: congestive heart failure, syncope, or angina. That is the time of intervention. And I think that should be over with. Now we should look at early signs, cardiac damage in the latent phase, with a supposed sweet spot for intervention, which has actually no harm and salvaging mortality. So this has been changed, and hopefully the upcoming trials will enlighten us further with both. Thank you very much for your attention.
Wonderful lecture as usual. Great thanks, Eberhard. The next speaker is Dr. David and Joel Cohen from Cardiovascular Research Foundation, USA. His title of lecture is Cerebral Embolic Protection for TAVR. Dr. Cohen, please.
Thank you very much. It's a pleasure to be back here and giving a talk that keeps evolving as we get more evidence. And I'm going to try to enlighten you about some of the recent randomized trials and also some registry studies. So we all know that stroke is still one of the most feared and devastating complications of TAVR. And despite a lot of advances in our devices and our techniques and our planning, stroke is really holding on steady at about a 2% incidence across the board, with a slightly smaller incidence of disabling stroke. We also know that cerebral embolic protection devices, in particular the Sentinel device, which is the one that's approved in the United States, capture debris in almost all procedures, and have been shown, at least in one trial, the CLEAN TAVI trial, to reduce new brain lesions by diffusion-weighted MRI. But what still is unsettled is whether these mechanistic effects result in clinical benefits. And so I'm going to talk about three things. First of all, is there still a problem? What have we learned from the available clinical trials? And for those of you who know the punchline, why don't we seem to get a benefit from the current cerebral embolic protection devices? So with respect to TAVR-related stroke, here are the incidences. It's probably best to just look at the blue line here, which is in-hospital stroke. And you can see it has been generally declining, with the biggest drop once low-risk TAVR was approved in the United States. But it's been really steady in the 1.6 to 1.4% range for the last 4 or 5 years in the United States. So clearly that's something we would like to avoid for most patients undergoing TAVR. And the reason why we want to avoid stroke is not just because it's a scary word, because it's bad. It is associated with excess mortality at 30 days, at 1 year, and 5 years. It reduces the amount of time patients get to spend at home where they want to spend their time, and it's associated with a cost of at least $9,000 per episode. So there are a lot of reasons why we would like to get rid of stroke after TAVR. So what have we learned from the trials that we have now? There have been at least 4 good-sized, good randomized trials in the TAVR space, and I'm going to talk about each of these as they go. The first large randomized trial in TAVR was the Protected TAVR trial, which was presented a couple of years ago at TCT and published in the New England Journal of Medicine. This was a US-based trial with 3,000 patients undergoing transfemoral TAVR who were randomized to TAVR without a cerebral embolic protection device, which is the Sentinel device. Everybody in this trial had a neurologic exam pre and post procedure, so they really tried to do very good surveillance. And the primary endpoint was stroke at 72 hours or discharge, whichever came first. Here is the primary endpoint, which showed no benefit. There was a trend, but it was not at all statistically significant with the embolic protection device. But when we looked at some of the secondary endpoints, there was this intriguing and tantalizing reduction in disabling stroke, which is the kind of stroke that we really would like to avoid for our patients. There were not benefits in anything else, but there was this 0.8% absolute reduction in disabling stroke. So we waited to see if this could be confirmed. And there was another trial going on in the UK called the BHF Protect TAVI trial, which was an even larger trial. This was a trial that ultimately ended up enrolling about 7,500 patients who were undergoing TAVI, who got, again, the Sentinel device or no embolic protection. It was a very pragmatic trial. It was done at all the centers in the UK, and about 30% of all the patients in the UK who underwent TAVR during the time of this study were enrolled. The sample size was increased because they had lower than expected event rates. The primary endpoint, just like in the previous study, was any stroke within 72 hours or before hospital discharge. And this one was actually powered to detect a smaller benefit, about a 33% reduction in the risk of stroke. And once again, they found no benefit with the embolic protection with the Sentinel device, really virtually identical rates of stroke. And when they looked at the secondary endpoints, somewhat disappointingly, the disabling stroke endpoint was not reduced either, although again there was at least a trend in the right direction. None of the other composite endpoints were reduced. They did a number of subgroup analyses, as one would like to do in these trials, to see if there was any group that derived preferential benefit, and this kind of noisy figure here basically shows there were no subgroups where there was enough of a benefit to really stand out, no specific heterogeneity of treatment effect. So here are the 4 trials now summarized. All the randomized trials that were conducted with the Sentinel embolic protection device. The first one, which was the smallest single-center study, was positive with respect to the endpoint of reduced new brain lesions by diffusion-weighted MRI. Then there was the Sentinel trial, which was the approval trial in the United States, which also had a MRI endpoint, which was neutral. And then the 2 large clinical randomized trials, which were neutral. So I think the question we're left with now, facing these data, is why don't this current embolic protection devices work? Why are these results disappointing? And I think there are several potential reasons for it, and they're all worth discussing. One is perhaps there are issues with the Sentinel device. It has rather large pores compared with some other devices that are coming along, and it only protects 3 of the 4 great vessels to the head. So maybe the solution would be that we need better devices with smaller pores and that protect the entire cerebral circulation. A second, I think, very plausible explanation is unintended consequences. And what do I mean by this? Well, we know that the Sentinel device catches debris almost every time you put it in a patient. There's always debris in the basket. So that debris was headed for the head. And catching that debris did not prevent a stroke. So one possible explanation is the Sentinel device, by manipulating it in the vasculature, in the cerebral vasculature, is causing as many strokes as it prevents. And again, here the solution is maybe we need better devices that are a little more gentle as you manipulate them. Although again, with experience, you can place the Sentinel device very, very easily in most patients. Or perhaps we just need more, greater operator experience to become more facile with this device. The third, and I think a very important component of the lack of benefit, is that the effect size that we imagined simply is smaller than what we hypothesized. And that's, again, we're having underpowered trials. Now, you may say, look, there's 10,000 patients who've been randomized in trials. How can that be underpowered? Well, the data would say it may be. Maybe we need even larger trials, or perhaps we just need to approve these things based on surrogate endpoints and let people use their judgment. That can be an interesting discussion. And then finally, I do think there is a suggestion that the trials have had the wrong endpoint. The trials have had the endpoint of all stroke. And what the trials show, if you look at them carefully, and I'll show you in just a second another data set that shows this, is that what embolic protection devices seem to do if they do anything, is convert the large strokes into smaller strokes. And so that's not, if that's the way that these devices work, that's not going to prevent strokes. It's just going to change the distribution between the larger ones, the more disabling ones, and that would be beneficial. Changing that distribution would be beneficial, and so maybe we need to change the endpoint to disabling stroke, but if you think the trials are large for stroke, they're going to be even larger if we needed to prevent disabling stroke. Now, I do think there is evidence, and we presented this a year ago and published this prior to the BHF Protect TAVI trial coming out, there's evidence from the TVT registry in prospectively designed studies with very rigorous methodology that we probably do prevent disabling stroke with the Sentinel device. This is a study that Neil Butala and I did where we analyzed 400,000 patients undergoing a first isolated transfemoral TAVR, and we looked specifically at in-hospital disabling stroke. We wanted to try to tease out this effect from the original Protect TAVR trial. And we used something called an instrumental variable analysis, which is taking advantage of a natural experiment. In the United States, the natural experiment is that patients generally go to the hospital that's nearest to them to get their TAVR. But hospitals have very, very strong practice patterns. And if you go to the Cleveland Clinic, there's a 95% chance you're going to get an embolic protection device. If you go to my old hospital in Mid-America Heart Institute in Kansas City, there is a 0% chance you're going to get an embolic protection device. So there's a natural experiment going on with these patients being almost randomized to getting these devices. And we can use methods that come out of economics to analyze that. And when we do that, what we see is that with respect to disabling stroke in this instrumental variable analysis, there is a statistically significant reduction. It's small. It's just a little bit bigger than 0.1%, but it's there. On the other hand, when we look at any stroke or we look at non-disabling stroke, it goes away. All the benefit here is in the disabling stroke. It's not in the any strokes. And in fact, this analysis was large enough to let us look at subgroups and to identify a couple of really promising subgroups. And those are patients with prior stroke. You can see here that the absolute risk difference is 0.6. That's a number needed to treat under 200 to prevent a disabling stroke. Valve-in-valve procedures, again, a very, very similar, pretty large absolute risk reduction. On the other hand, this is an intermediate risk group. Patients with PAD did seem to have a trend towards a somewhat smaller benefit. And the group that was actually most surprising to us is this one, where we saw no difference according to the valve morphology, whether it was bicuspid, tricuspid, or other. I don't know what other is, four leaflets or something like that. But we did at least have some promising groups of patients with prior stroke and valve-in-valve procedures. So at this point, in middle of 2025, my own thoughts about embolic protection devices, first of all, stroke is important. It's significant, it's unpredictable, we should do anything that we can within reason to prevent it. Embolic protection devices do what they're designed to do, they capture debris. And they may reduce the volume of new brain lesions depending on which study you look at. But the clinical benefit remains uncertain. If it's present, the benefit is probably related to just disabling stroke, and probably across the entire population is very small, with a number needed to treat about 800, which is awfully prohibitive. It's somewhat difficult to identify subgroups with consistent benefit, but our analysis that I just shared with you does suggest that patients with prior stroke and valve procedures, which are increasing every year, are going to be the ones who benefit most, and those might be promising groups to both study in future trials and for us to use in our clinical practice. And finally, and I think very importantly, we need other devices. We need better devices, and these need to undergo rigorous evaluation, ideally for stroke prevention rather than surrogate endpoints, although I think that's going to take a very, very brave company to do that in the current era. Thank you very much.
Thank you very much, David. So our next lecturer is Kentaro. Hayashida is going to talk about current status of M-TEER in Japan, the OCEAN-Mitral Registry.
Okay, thank you very much, Alan, for the introduction. So, ladies and gentlemen, it's my great pleasure and honor to represent our OCEAN-Mitral Registry here today. And this is the roadmap of the mitral procedure in our country. And it was performed in 2003 as the first in human, and the CE mark was approved in 2008. And we started the clinical trial for the mitral in 2015. Finally, this device was approved in 2018, and we are also using Eberhard Pascal, so we are using two devices in our country at the moment. And I was quite lucky to be the part of the national PI of the AVG 514, and we started the procedure from 2015. And we published the data on our initial result that the mitral curve device decreased the MR, not only MR, but also the symptom, and the QOL was improved with this mitral curve device. And we are organizing Ocean SCD family. So here today, so we have a lot of friends from our Ocean SCD family. And we're including not only TAVR, but also the mitral TEER and the appendage closure. And we have enrolled more than 5,000 mitral TEER cases at the end of the last year. And we published more than 160 papers so far, including 128 TAVR, 26 for mitral, and 10 for appendage closures. And I'd like to introduce some papers from our registry. So our good friend Mike Saji demonstrated the 30-day outcome after mitral TEER. And atrial functional MR was associated with a little bit lower procedure success rate compared to other primary or ventricular functional. But we need to be careful for the patient selection for atrial functional MR. And Dr. Shunsuke Kubo demonstrated the one-year outcome after mitral TEER. And the MR2+, that means the moderate MR was associated with the worst outcome compared to the mild or non-MR after procedure. So we need to try to minimize the residual MR after mitral TEER procedure. And Dr. Hyuki demonstrated the difference between women and men. And as usual, the women was much stronger than men, and women did better than men in terms of the better prognosis after mitral TEER. That is totally similar to that of the TAVR device. And Dr. Imamura developed a new score to predict cardiac death after mitral TEER. He included the heart failure admission and inotrope use and the benefit level to establish the prediction model. And area under curve is quite high, 0.7. That means a very good prediction. And Dr. Higuchi also demonstrated that if the patient was underweighted, and that means the patient had the worst prognosis compared to normal weight or overweight. That could also be associated with the frailty status of the patient. And Dr. Sugiura demonstrated the impact of the cardiac damage in the MR patient after mitral TEER. If the patient had the stage 3 cardiac damage, like RV damage, and it was associated with the worst outcome compared to a lower cardiac damage cohort, that means that we need to, we cannot miss the timing to proceed in mitral TEER. And Dr. Tetsuya Saito also published the impact on the beta blocker uptitulation after mitral TEER. If we can uptitrate beta blocker after procedure, it was associated with the better prognosis compared to the no beta blocker uptitration. So as far as we can do, we need to uptitrate the beta blocker after procedure for the functional MR. And Dr. Tokuda also demonstrated the impact of the clinical frailty status, and as well as the TAVR cohort, and the clinical frailty status demonstrated the worst outcome compared to a lower clinical frailty status. And he also combined the post-procedure MR grade 2, and if the patient had the worst frailty scale, and if the patient also has the worst residual mitral regurgitation, the outcome will be very bad. So we need to optimize the procedure outcome, as well as we also need to do the very good patient selection. And Dr. Mike Saji also performed the study on the hand grip strength as a marker of the frailty in patients with mitral TEER. If the patient had the weak hand grip power, it was associated with the worst outcome. That means this is also can be a very easy evaluation method for the frailty. And Dr. Ono also explored the impact of the worsening of the LVEF after mitral TEER. Usually after mitral TEER, the patient sometimes developed the worsening of LVEF. However, it didn't impact the long-term outcome after mitral TEER. That means the LVEF is just a sign, and it just represents the real power of LVEF after mitral TEER, so we don't need to care about it. And Dr. Yusuke also demonstrated the mitral TEER for the patient with very small mitral valve area. And as far as we can tailor-made the procedure steps, so we can achieve very good results even with the patient with very small mitral valve area. So we don't need to hesitate the mitral TEER for the patient with the MVA smaller than 3.5 square centimeter. And Dr. Yamaguchi also published the mismatch between residual MR and left atrial pressure predicts the prognosis after mitral TEER. And that is the re-evaluation of the paper by Dr. Paul Samraja. And we also have the same results compared to the previous study. And our registry also published the same result. And recently, we performed the comparison between our mitral registry and review of MR registry. That means they have the single cohort registry of the only atrial functional MR. And if we perform mitral TEER for the patient with atrial functional MR, and TEER did better than the medication group, that means the mitral TEER was associated with a little bit worse technical success. However, if we can do the mitral TEER, maybe we can improve the prognosis of the patient. And last but not least, our good friend Yohei Ono published the paper on the impact of procedural or new onset TR associated with the worst outcome after mitral TEER. If the patient doesn't have TR before procedure, however, if the patient developed the new onset TEER, it was associated with the worst outcome compared to other residual or normalized or no TR. That means that we need to be careful of the TR. And maybe in the future, the transcatheter tricuspid intervention may improve the prognosis of these kind of patients. So we're organized PCI Tokyo Bath meeting from 2013. So if you're interested, you're most welcome to attend our meeting. So thank you very much for your attention.
Thank you. Wonderful lecture. And next speaker is Dr. Kent Hyo-Soo, Prince of Wales Hospital, Chinese University of Hong Kong, China. His title of lecture is Current Landscapes of Tricuspid Valve Intervention in Asian Pacific Region. Dr. Soo, please.
Thank you. Thank you for the kind introduction. So it is my great honor to share on the topic of current landscapes of tricuspid valve intervention in Asia Pacific region. So here's my disclosure. So we all know that TR is actually a very common disease and is now no longer a forgotten valve because it's associated with significant morbidity and mortality. And open heart surgery has been rarely performed because of the high surgical operative risk. And currently, there's no medical therapy that has been proven to alter the clinical outcome in terms of heart failure, hospitalization, or mortality in patients with TR. And therefore, over the past few years, there has been intense interest in transcatheter interventions for TR. And in particular, in the Asia-Pacific region, we have very specific features. We have significant difference in healthcare system. We have reported similar prevalence of TR compared to North American or European registry. But then, at the same time, we have very limited device options, and we have different etiology distributions across different regions in this part of the world. And there are more degenerative or rheumatic causes than reported in North America or European registry. And our patient, most of them actually comes in quite late. So early in 2021, in Europe or in United States, there has been quite an extensive different gadgets to treat TR, including an orthotopic valve replacement, heterotopic valve replacement, leaflet approximation device, and also a transcatheter annuloplasty device. However, these devices actually comes into Asia quite late, but then what we are seeing in the past few years, there has been different patterns of practice in this region, not just by adopting the Western device, but there has also been local innovations in treating TR patients in this locality. So tricuspid agitated repair using a tricuspid device is still the most commonly performed procedure in this region, although still limited. But then in mainland China, they also innovate the Dragonfly device. We don't have the Evoke TTVR device in this region yet, but then again, another local innovation using a transjugular TTVR using the LuxValve device was actually invented back into around 8 to 10 years ago. And at the same time, we are also trying to adopt the cavo valve implantation, introducing another transfemoral valve TTVR device from Israel, the cardio valve. And also, there has been 2 other very special local innovations, including the focal annuloplasty delivered via the transcatheter access, the K-cup device, and also another Korean company device, the Pivot TR, a spacer device that is developed and is under an early investigation. So these are sort of like the brief landscape of the tricuspid valve intervention in this region. So then I would try to share some of the initial Asia data. So this is our initial Asia-Pacific experience of the T-TEER procedure. This is just a very small-scale multi-center registry of around 100 patients, but they tried to report the early data of around 30 days in T-TEER procedure in APAC region. In fact, you can see the TR reduction around 3/4 of them actually achieve less or equal to moderate TR, and more than 95% of the cases we're able to achieve at least 1 grade reduction of the TR, and that's actually very comparable to the published data in Europe and also in the United States. And the major adverse event rate was only 1.9%. And in the analysis, we were also able to find non-torrential TR at baseline, and also increased clinical experience were associated with improved 30-day device success rate. So the other device that has come into interest is the transjugular TTVR device that is developed in mainland China. So there's single-arm registry involving 126 patients in 8 centers in China actually has shown very impressive TR efficacy with a 1-year all-cause mortality of around 10%. Most importantly, when compared to the other transfemoral TTVR device, the pacemaker weight, the new pacemaker weight in this cohort of patients was only reported to be 1.6%. And that was actually very important, driving us to draw a need to have a head-to-head comparison with different kind of TTVR platform, especially in patients with CIED. So we also have a compassionate registry involving 70 centers around the world, involving 99 patients. In particular, we tried to analyze 36 patients that has a CIED in situ that has an implantation of the LuxValve Plus platform. And you can see that no matter all the procedure success, 30-day mortality, and also TR reduction or heart failure improvement in patients that has CIED versus no CIED, when they subject to transjugular TTVR, there actually no significant difference. And notably, around 9.1% of the CIED patients has worsening of device parameter, but none of them require a lead replacement, and that is actually very important. So the other important device is the transjugular focal annuloplasty K-cup device. And again, this is a device mainly now performed in mainland China, and it's actually just approved by the China NMPA. The TriStar device, the TriStar study is actually a single-arm prospective study involving 96 patients. And in this study, very impressively, again, the TR was significantly reduced in over 94%, and in over 85% of cases, they have a 2-grade reduction. And in brief, this device is delivered using a transjugular access and then apply a clip at the tricuspid annulus and then sandwich a tissue at the tricuspid annulus in order to reduce the tricuspid annular dimension. And the safety profile in this registry was also quite impressive, of only a composite endpoint of around 18%, including minor bleeding in the procedure. So the other local innovation is the spacer device that is developed from Korea. We are aware that this device now is going into the international market, starting with a compassionate use application in different regions now. But the first in human implantation is actually performed in Korea. And it's actually a novel spacer device delivered across the tricuspid valve vertically. And the anchor is reliant on the pulmonary system and also the IVC. And in this first in human series, all the 7 patients has a TR reduction and there's no complication. And the company is actually driving a larger scale study and also introducing compassionate use as just mentioned. And the last device that I want to share is the heterotropic TTVR that's available in a selected site in Asia Pacific region. And although the device itself is not treating the TR, but you can see from this white heart cath angiogram, white heart cath hemodynamic tracing on the white bottom, in the RA and also IVC pressure, you can see that it's actually a very significant difference across the valve implanted site, driving us to believe that there could potentially be symptomatic improvement, especially in the lower extremity edema or hepatic pressure. Of course, the long-term impact of this device to RV remodeling or the hospitalization in this patient is requiring further research and study. So having introduced quite a number of different devices, in fact, one of the most important aspects of tricuspid valve intervention is on the imaging. So apart from transesophageal echocardiogram, 3D and also 4D intracardiac echo actually plays a very, very important role. The 3 catheter, Philips, Siemens, and GE partner with J&J has been gradually launched in different parts in Asia Pacific region, and is actually playing a very important role as a supplementary in tricuspid valve intervention, including edge-to-edge repair and also in valve replacement technique, hoping to optimize and streamline the procedure. So having said that, we do have a lot of different treatment options. TR is actually far more complex than the other valve. A multidisciplinary heart team evaluation in order to help the patient make a reasonable decision, which include different options like medical therapy, palliative therapy, even for surgery, or different kind of transcatheter therapy or investigational device is actually very, very important. There is also a lot of unanswered questions in TR treatment, like the value of rhythm control, whether valve repair versus replacement is important, what is the role of medical therapy, and also relationship with HAPAP. These are a lot of unanswered questions that requires further investigation. So to conclude, TR is actually associated with significant morbidity and mortality. There has been remarkable advancement being achieved in the past decade, and the heterogeneity in TR pathophysiology in APAC require a more targeted clinical approach. Thank you very much.
Thank you very much. Our last lecture is to be given by Duk-Woo Park. It's what is the best medical therapy for TAVR patients?
Okay, thank you. So my topic is about the innovation, non-device pharmacology therapy. What is best medical therapy for TAVR patient? This is my disclosure. So, and over the last 10 years, most of the TAVR trial mainly focus on indication expansion. So, but looking at the pathophysiology of severe AS, there was mainly involved in valve disease. Also, there was involved in the myocardium itself, and time goes on, fibrosis and hypertrophy progress, and the maladaptive cardiac remodeling is happen. So, and even though and the treatment of valve and the patient suffering from heart failure symptom, and there are many symptoms from the maladaptive remodeling. So for reversal of such cardiac remodeling, many proposed mechanism was suggested. That this is from Martin Leung's slide, and the RAS inhibitor or ANI or SGLT2 inhibitor, and such proposed mechanism can protect the heart damage during the progressive AS, also augment its recovery after surgical AVR or in the TAVR procedure. So, and among them, SGLT2 inhibitor is a very nice novel drug, and initially invented for diabetic medication, but is
remarkable reduction of heart failure admission as well as a major adverse event, the death, MI, stroke, or now is approval for the heart failure medication. And very interestingly, and that was published in the New England Journal of Medicine and presented ACC and the TCE at Chicago and the TAVR Registry. They evaluated the open label comparison random trial for targeting half rep and the reduced ejection fraction. There was a simultaneously published TAVR trial. At the designing our defined TAVR trial that was actively ongoing. So, and as mentioned in the background, the TAVR patient still, even after successful TAVR, 1/3 admission of heart failure also, and there are many medications suggest for management of heart failure, and there is no established management for post-TAVR patient. And this TAVR trial, pragmatic, open label trial, not double-blinded trial, 1-to-1 randomization, and the dapagliflozin versus no dapagliflozin on the standard of care. And the inclusion criteria mainly targeting reduced ejection fraction less than 40%, or diabetics or CKD, and there is some exclusion criteria. And the primary endpoint is all-cause death or heart failure worsening, and the diverse secondary endpoint was adapted, and the 3 months or 1 year outcome assessment, and that was done in the Spain, and approximately 40 center, and the 1,000, approximately 300 patient was enrolled in this trial, and the overall 620, 640 is the randomization, and at the post-TAVR, successful TAVR and the randomization, and the open label dapagliflozin versus no dapagliflozin, and in dapagliflozin group, there is a higher crossover, it's 17% of crossover. So, and overall 82, very old age, there was a usual pattern of the TAVR patient, and the half of patient woman, and the diabetic is a 43, and the low ejection fraction is approximately 17, and the CKD patient is nearly 90%. And the primary endpoint, the death of heart failure admission at 1 year, control group 20%, and the dapagliflozin open label group, and the 28% reduction that was statistically significant, and the overall effect was consistent of various anatomical or clinical parameter, and the diabetic group and the ejection fraction group is very interestingly even more than 40% that there was a statistically significant effect. And the EGFR, regardless any EGFR result was consistent. All-cause mortality was no difference. The main difference was driven by worsening heart failure. It's nearly 37% reduction. And the secondary endpoint in the heart failure and the urgent heart failure visit, cardiovascular death was no difference. And the death or CV death or hospitalization was positive. And the secondary and safety endpoint we know, and the SGLT2 inhibitor is frequently associated genital urinary infection, but there is no difference in the sepsis and the bacteremia and the higher incidence of genital urinary infection. And the TAVR trial, even open label trial, confirmed the post-TAVR patient combining heart failure and the half rep and the dapagliflozin reduced all-cause death or worsening heart failure. What are next? You know, in TAVR patient and the 20% combining half rep, low ejection fraction, remaining 80%, usually ejection fraction okay, more than 40%. And the severe AS and elderly patient very frequently combining half PEP preserved ejection fraction because of advanced aging, and combine the cerebral comorbidity like hypertension, AFib, coronary artery disease, obesity, pulmonary hypertension. There was a provocative and the risk factor for half PEP. And in the we know well, based on the JAMA article, STS TVT registry, 30% post-TAVR patient experienced heart failure readmission even in 1 year. And the SGLT2 inhibitor was not tested in the half PEP preserved ejection fraction. And even in half PEP, there are very nice randomized trial, Emperor preserved and deliver trial confirmed SGLT inhibitor can work even in half PEP patient. There was in the targeting HAPEP and most of exclusion criteria of severe AS, and the TAVR trial. This is a not open label trial, double-blinded, placebo-controlled trial, and evaluating novel SGLT2 inhibitor TAVR glucoprotein. And this is, we are targeting more than 1,040 patients, severe AS, and the HAPEP, preserved ejection fraction, and the randomization 1-to-1 ratio, new SGLT2 inhibitor enabogliflozin versus the matching placebo double-blind trial, and the enabogliflozin new version of SGLT2 inhibitor, and the 0.3 milligram is equivalent dose of MPAR or DAPA 10 milligram. And our main targeting after successful TAVR and mild reduced or preserved ejection fraction EF more than 40%, and combining structural heart disease LVH or LA enlargement, most 100% involving this year, based on anti-pro-BNP more than 300 without APIP, and the inpatient with APIP is 600, and this value is consistent MPRO preserved and delivered trial. And the primary endpoint was the MACE or heart failure hospitalization MACE, defined all-cause death, non-fatal MI, non-fatal stroke, and the secondary endpoint we will evaluate the diverse renal endpoint. Also, we will do core measure the some cardiac function. It's about the reverse cardiac remodeling based on serial echocardiography core measurement. And we will do a randomization after successful TAVR within 2 weeks, and the 1-to-1 double-blind passion trial TAVR glucoprotein or matching placebo, and the sample size was very similar to TAVR trial, and the usual care group we expected 30% event in the primary endpoint, all-cause death, MI stroke, or heart failure readmission, 90% power, relative reduction 30%, that was identical to TAVR trial, and we expected approximately 1,040 patients would be provided sufficient power. And in South Korea, and more than 40 centers actively joining, we started from this year and until recently, and the 68 patient was randomization 6.5%, and we expected 2 or 3 years for full complete enrollment. This is my final message. Updated OMT for TAVR patient. TAVR confirmed SGLT2 inhibitor result in the all-cause death or worsening heart failure, mainly targeting HAPR-REP population. And TAVR trial investigator-initiated multi-center double-blind random trial evaluated novel SGLT2 inhibitor TAVR glucoprotein can improve clinical outcome, mainly targeting in the HAPEP patient, and those cumulative evidence strongly support the role of SGLT2 inhibitor for heart failure worsening, reverse cardiac remodeling, and reduction of major cardiovascular outcome in TAVR patient. Thank you for your attention.
Thank you. Any questions for any of our or comments maybe? Easier. Duk-Woo, I think we know that a lot of the patients undergo TAVR still come back for both heart failure as well as atrial fibrillation. That's the majority of the sort of remission. And I think your trial, does it have any of the AFib endpoints as well, or for all your SGLT2 inhibitor study?
Yes, so we guess the overall population among 30% could be combined AFib population. We also have some secondary endpoint AFib, and for enrollment, regardless of AFib or normal sinus rhythm, in any exclusion criteria, all patients will be included. Also, anything about the standard medication is almost the same. Yes.
Can I ask David, your personal thought? You nicely demonstrate that the main target of protection device is to reduce disabling stroke. But overall, the NNT is about 800 persons to protect just one disabling stroke. But when we focus the indication narrow down to the patients with previous history of stroke or VIV-TAVI, NNT declined to 170. So what's your thought? Just do protection all the patients, or just indicate patients?
I think right now, my belief is we need to we need to target, because the devices are quite expensive still in the United States. It's about $3,000 when we use them. And, it's clear that, if you have to treat, in my center, we do 600 TAVRs a year. We still wouldn't prevent even one disabling stroke based on the number needed to treat of 800. So I think looking for those groups, and I think, again, we've identified a couple of them. The other groups that are at risk is women. Women are consistently have twice the stroke rate as men in these studies. There is a suggestion, although it hasn't come out in the head-to-head studies, maybe self-expanding valves where you may manipulate it more as you're deploying it several times. So I think we need to continue to work on refining the population until we have devices that are so easy to use and so perfect that we don't have to worry about those things. That's my personal belief, because disabling stroke, I really do think that's the target. It's what we want to prevent, but it is rare enough that it's very hard to do a trial that was designed to prevent that. You'd need a trial of 50,000 patients to design a disabling stroke trial. Nobody's going to do that.
Eberhard, your message is very clear. Asymptomatic severe AS, just early intervention rather than watchful surveillance. And moderate AS, watchful waiting is a reasonable option. To my understanding, on the TAVR trial, there is a difference mainly on the switch to the intervention in the patients with watchful waiting. But I think there is no difference in cardiovascular death. Thus, I think watchful waiting may be another reasonable option for asymptomatic severe AS. What's your thought?
Exactly what you're saying. That's my thought too, because actually the trial was positive because of rehospitalization issues. That's really where the difference is, not so much on stroke and on death. I think the excitement really was that we had a positive study. But now looking a little bit deeper, a little bit further, I think there are some points that you were just raising. Be a little bit more careful and maybe less optimistic as far as early intervention is concerned. And I do agree with what you're saying, exactly right. The very unfortunate thing on moderate, however, is that, as you know, the trial was prematurely ended for reasons basically that the funding went over to Progress, and we have to see what that shows. But I think overall we should not stop thinking about early intervention. And when you look at the OCEAN trial, and I watched it very, very carefully, what Kentaro said, even though it's mitral, basically we try to avoid cardiac damage that is too far extended. And we do have means now in imaging that could identify those patients. So in all, I think I agree with what you said. The trial is, it's not that positive because you don't reduce death and stroke, much rather than rehospitalization. Whether that's enough, I don't think so.
David, let's have the last comment to this session.
I'm just going to add in a little bit to what Eberhard said, and because I think it is the early TAVR trial is a complicated trial because of the endpoint, and just 2 points I want to make. One is that if you look at the more traditional endpoints, because you're both right that what drove the endpoint in early TAVR were the first 6-month crossovers, which were considered part of the primary endpoint, and I think a lot of us wish that they weren't. If you look at in the New England Journal paper and in subsequent papers, we've analyzed other endpoints that are more traditional, like death or heart failure hospitalization without the early crossovers. There still is a benefit. It's not as striking, but there is a benefit there. So that's point number one. Point number two, which I think is often lost here, is that the surveillance in early TAVR was world-class surveillance. It's surveillance like nobody's ever done before. And the reason for that is because all the patients, before they came into the trial, had to be evaluated for and had to be shown to be suitable for TAVR. So they had their CT, they had their coronary angiogram, they had all of those things. They knew what TAVR was. And as a result of that, when they reported any kind of symptoms to their doctors, they were ready. I mean, they could be treated within days as long as there was an opening. It's the United States. We always have an opening for a TAVR, so we can do that. So I think that also made the trial a little unrealistic because the surveillance was probably too good and beats anything that we normally do in practice. So I think we have to keep both of those points in mind. But I think your point about the primary endpoint is tricky and does, and warrants everybody paying attention to it.
But just one comment is that a truly asymptomatic patient is the difficulty too, because if you spend enough time, these patients likely have symptoms, and also obviously in early TAVR you do a stress test, right? So you do that.
I mean, the stress test was a decent chunk of patients failed the stress test and then fell out.
Right.
These patients who got in, they were really asymptomatic. Their KCCQ scores were 92. My KCCQ score on a good day is 82. So I think you have to just kind of keep that in mind.
But when a patient are truly asymptomatic, it's just the same thing, meaning that you're taking through a treatment that is not risk-free, right? So you end up with a stroke, you end up with something. It's difficult because they are doing perfectly fine. Your score is high, and
I think as a clinician, it's very difficult to
clinically it's hard. The trial is a different thing, but it's a clinical thing. If you really determine to be asymptomatic, you say, well, let's have the TAVR tomorrow, and then you end up obviously not so good, for example.
No, I mean, in the trial, it was, perhaps lucky. There were no procedure-related strokes and no procedure-related deaths, but in real life, you're going to have something. Yeah, I think you're right.
Okay, well, thank you very much for a very excellent session. So I'll turn it over to the next group.